Hi,
Should
good
we
evening,
start now,
Vas.
sir?
Hi.
Should we start now, sir?
Yeah, let us start. I am in time.
We have
Yes,
to.
not in time. Okay. So, Shabir sir, if you can unshare the slides, we can show the intro slide, then we
Absolutely. Yeah, no problem.
can share the introduction slides, please. So it is my pleasure to welcome you all to this 169th edition of Thursday Musings on a slightly and a very controversial topic. We have a speaker from a different time zone. Thank you so much, sir, for spending your time with us. Next slide, please. I'll be handing over the session to Professor Dr. Tufan Pati, sir. Sir is the chairman of this program. The participants will be on the mute mode. They can put their questions in the chat box. The meeting will be recorded and later put on our YouTube channel. Sir, over to you. Apologies for not reading your CV in full.
Thank you. Thank you very much, Alim. Again, thank you for not reading the CV. We are going to hasten the process and listen to the important, interesting, controversial topic about euthanasia. Next slide, please. And I welcome to our midst our usual vibrant moderators, Dr. Amit Paturusi, Professor of Psychiatry in High Tech Medical College and President of IPS Eastern Donor. Next one, please. Dr. Alim Siddiqui, Professor of Psychiatry in Lucknow Medical College and Treasurer of Indian Psychiatric Society. Welcome all both the moderators. Next slide, please. I am very much pleased to invite and welcome Dr. Sanjay Kumabat, my dear friend from Mumbai, as the Director of Insight. Hello, Dr. Kumabat.
Good evening.
Good evening. Director, Insight Mind Care Center, Thane, and former Superintendent of Thane Mental Hospital, consultant psychiatrist, and expert in forensic and legal aspects of psychiatry. Welcome, Dr. Kumabat. Next slide, please. Next one. Dr. Abhay Matkar, another good friend. S.M. Matkar, Dr. Abhay Matkar, Professor and Head of Department of Psychiatry, SDM Medical College. He had been elected the President of IPS South Zonal Branch for the year 2023-24. He is the first doctor to be elected from the entire North Karnataka. Dr. Abhay Matkar, after having served Army, joined SDM Medical College in 2007. He has been Secretary and later President of Hubli IMA, Chairman Election Commission, and Director Council Member of IPS. President of IPS Karnataka chapter, where he has received the Best State Branch Award. He has many research papers to his credit and is popular teacher in SDM. He has visited many national and international conferences and given scientific lectures. With this, I hand over the meeting to Dr. Matkar and Dr. Kumabat. Please take over. Someone will introduce the speaker and the other will introduce the topic of debate, and we move on with the program.
Dr. Sanjay, sir. Sanjay, sir, please unmute.
Yeah, am I audible now?
Yes, sir.
Yeah, Dr. Shabir Amanullah, who has completed his education from India from Central Institute of Psychiatry in Ranchi and MD from Nimans, Bangalore. After moving to UK and completing his MRCP, he moved to Canada and he settled in now Ontario, Canada, and has chaired various national and international organizations related to psychiatry, particularly geriatric psychiatry. And also he had been Oxford County Medical Society's president of Canadian Academy of Geriatric Psychiatry. And he has won many awards, has awarded outstanding contribution to his geriatric psychiatry by the Canadian Academy of Geriatric Psychiatry. So such a absolutely very well acclaimed speaker we have today. We are fortunate enough to listen to him on relevance of euthanasia in psychiatry. Next, please. And we have expert Advocate Nikhilesh Ramachandran from Supreme Court. You is widely recognized as the foremost practitioner, having vast experience of almost 3 decades in handling legal matters of general litigation and corporate law. He is also appointed as standing counsel for the state of Kerala in Honorable Supreme Court of India, and it was entrusted with matters of varying issues involving the state government. He is engaged in various cases of national and public importance, both appearing for the state and the central government, for the Supreme Court and the High Court. He is a part of the litigation wherein the Honorable Supreme Court has pronounced landmark judgment, which is of significance in public importance. So, welcome, Professor Advocate Nikhilesh Ramachandran, and over to you, Dr. Alim, please.
Yes, sir. Abhay sir, any words from your side?
Yeah, at the outset, I would like to thank the organizers for giving me this opportunity. And I find that this is one of the very important topics which is being discussed worldwide, which has got many ramifications. We should not just see it from the context of the medical aspect per se. Like we have today speakers who are speaking from the geriatric type, we are getting speaker from the legal context also. So we need to look this particular aspect through various dimensions and address to it in a very important way. And I'm sure both the speakers will be able to give a lot of insights into this particular issue. Thank you so much, Dr. Alim. Over to the speakers. Thank you.
Yes, sir. Shabir sir, over to you. Please start.
Okay, wonderful. Thank you. Let me just make sure this is the right one. Yes. Okay, perfect. All right. Well, thank you so much. It truly is an honor for so many different reasons. The first is I have a gentleman who got me into psychiatry, Dr. Rao. An amazing mentor, a very nice human being. I remember he used to come and pull me out of medical ward rounds and take me and show me psychiatry cases. Such was his dedication to his students. In cultural activities, I used to be very active in college. He used to always nurture that. I don't remember a single occasion when he would not have a good word to say to encourage someone. So I'm truly grateful. Professor Mohan Isaac, another amazing individual. It's an honor to present with him attending from Australia. He has single-handedly been able to develop very powerful tools in teaching. Just one second. One second. Dr. Murali is also there. It truly is an honor to be here and to present in front of so many doyens of psychiatry, as I would like to say. And I'm missing out so many names in interest of time. It is an honor to be here. Thank you for inviting me. This topic is not just pertinent, but it is going to become a very contentious issue in the next few years. And I can see it evolving into becoming more and more complicated as longevity increases. We are all living longer, and it's going to become increasingly difficult because, number one, cost of living is going up. We are seeing many variants of diseases. Forget COVID. We are seeing so many other illnesses manifesting itself, and we don't understand what the evolution is going to be like. So I do have a few disclosures to make. But before that, I would like to ask this question to everybody so we can keep it in mind. But death, we know, is inevitable. But would choosing how we die be a blessing? It's a question we all need to ask ourselves because we're all heading that way. It's about how we prepare for it that becomes fundamentally important. I have given a few lectures on behalf of pharmaceutical industries and ad boards. I have received grants as well. I have a patent I've applied for. I don't have any conflict of interest. And I would like to acknowledge some of the help Professor Mohandas has given me over the years in some of the work I've done. So euthanasia, when you look at
what it really means, it basically boils down to the fact that it means that it's a good death. Now, it's not new. We often like to think that what happens today is often very unique and we are highly advanced as a civilization. The truth is, many things have happened before. We tend to revisit these things over and over again when there is a buildup of various social confluences that lead us to coming to a point in time where we have to address it. Otherwise, we don't think about it. So the practice of intentional ending a life to be relieved from pain and suffering, and I've taken this from Wikipedia, is basically one of the key ideas behind euthanasia. Suicide, on the other hand, is an act of causing one's death. And murder is obviously killing another human being without justification and with malice. Manslaughter is killing in the absence of malice. The reason I have put this here is it becomes very important to help to dissect in our minds what the differences are between the various types of death that occur. So when we talk about euthanasia versus assisted suicide, it is important to realize that there are various different areas and aspects that we have to cover. The first being, when you talk about euthanasia, active steps are taken to end life. This is primarily to stop suffering. However, the final act is undertaken by someone other than the individual. For example, a doctor. If a person concerned has requested this, it's called voluntary euthanasia. And the main difference between euthanasia and assisted suicide is who performs the final act. So when you push the plunger on the syringe, the person who performs that act is what decides the difference between euthanasia and assisted suicide. Within assisted suicide, you have assisted dying, assisted suicide, and palliative sedation. Assisted suicide can be used to mean both euthanasia, generally voluntary and assisted suicide. Assisted suicide is helping someone to take their own life at their request. Okay, so we briefly spoke about it as well. And some of these concepts can be very, very fluid. And it's important for us to know that we are trying to create some kind of a barrier so that it doesn't create much confusion and we have something to reference. Palliative sedation, on the other hand, is you keep a person sedated until such time that they die. This usually with chronic pain and conditions like that. So what are the types of euthanasia? We have voluntary, involuntary, and we also have non-voluntary. Sometimes these definitions can seem a bit dry, but this is where the problems arise. And this is why we have a lawyer on the panel, because it's being able to help us to distinguish where the law stands versus where we stand medically. So when it's non-voluntary euthanasia, the person is not able to give consent. So for example, because they're ill, they're comatose. So you have a substitute decision maker. You have a power of attorney. You have somebody who steps in to make that decision at that point in time in your life. So if you have severe cancer, you're currently on medication, there are metastases to the brain, you're still alive, you have somebody who can make decisions for you when you cannot make it. It's usually based on suffering, pain, and quality of life. What about involuntary? Involuntary is the person is able to provide consent, but you have not asked the person. So when you look at things like what Harold Shipman did, Harold Shipman, in his argument, would state that he asked these people they were suffering, but in reality, it wasn't a discussion that really took consent such a. So it is actually deemed as involuntary. In Canada, we had a lady who was actually killing patients who were older, Elizabeth Wetlaufer. So if you look it up, you can actually see that. So this is basically murder. Voluntary is when the request is made by the patient. The patient is competent and consents. You will see these terms emerging many, many times in our discussion today. Competency and the ability to give consent. Now, voluntary euthanasia has been made legal in many places, including in Canada. So the request is made by the patient. We spoke about how there's competency required, consent is required, and some of the countries and states in the US where this is permitted. Canada, we've had a lot of issues. What about globally? So this is from Wikipedia. If you look at this map, when it says red, all forms of euthanasia is illegal. So that's both passive and active. Okay, so active is when you do something to cause death. Passive is when you stop doing anything to maintain life. Okay, so there's a difference between the two. So if you look at the graph, if you look at the picture in front of us, the areas in blue are where active euthanasia is legal. And there are a number of countries, and this does not list all of them. There are a few other countries as well. So why is it that we see this big breakup versus one area where there's so much of resistance to it? You'll see as the discussion goes on, some of the things that shape it. Voluntary euthanasia. Now, the pharmacokinetics and pharmacodynamics listed for medications are usually what we use for MAID, and I will go through it as well. But here's the important part. There are patients who undergo MAID or the medical assistance in dying or euthanasia that find the experience extremely distressing. And we don't talk about this very often, but it's very important to keep it in mind because we don't recognize what is it that goes through a person's mind. So for example, if somebody is opting for euthanasia, but as you're giving them the medication, then they're going through a very distressing phase, are they able to reverse the decision? Are they able to say, stop, I don't want to go ahead with this? Or is it the decision that they made that still holds through irrespective of the process? It becomes very difficult because you know that there are patients who don't want to die while they're dying. What if they're too sedated to speak up? So when you talk about non-voluntary euthanasia, and we say the person is not able to give an opinion due to ill health of the state, and you have a substitute decision maker stepping in, what happens if at that point in time, the person who is making the substitute decision is not aware of what the patient actually would have wanted because there was no living will? So, like I said, we often like to think that these are new things, newer concepts. They are not. So if you look at this article in The Guardian, going back to 2019, euthanasia obviously was illegal in the UK at that time. And you couldn't really do anything because you'd be charged with murder. But in 1936, there was a very powerful man, King George V, right? Imagine, he was an emperor, very powerful man. And this actually should humble us because it tells us that one of the greatest things we can achieve in life is at this point in our lives is if we have good friends, good social supports, and people who care about us. If we reach that stage and you don't have the support systems, imagine what a lonely place it is. So imagine an emperor going through extremely difficult stages of his death and wanting to die. So with the king's health in decline, and by early 1936, it was clear that the end was near, Lord Dawson was the chief physician at that point in time. He knew death was near. But at that point in time, nobody knew what had happened. Later on, it was revealed that his death was quote unquote engineered. He actually administered a lethal mix of morphine and cocaine. Interesting, isn't it? Cocaine was used to hasten his death. Whether cocaine at that point in time served another purpose beyond accelerating death, while morphine caused suppression of breathing and caused death in that way is very interesting. But the combination and the fact that people even thought about it is fascinating. Hours of waiting just for the mechanical end, when all that is really life has departed, only exhausts the onlookers. And we know this when you go to the CCU and people are dying and they're very sick. It's a very painful process for all of us. We don't know what's going on through the mind of that person at that point in time. But if there's pain and suffering, then euthanasia has a role. And this came up many, many years later. Now, is this unique to England? No. So if you look at a cross-section of things across the globe, in Japan, they used to call it obasute, where they would abandon the elderly to die. And there's still cases from 2015, 2018. So this is not something that's unique to one particular area. It looks as if across humanity, there have been different epochs, different periods in time where these practices were carried on. So why was it done in Japan? Well, they felt many people when there were food scarcities, when there was famine, when they were too old to be of quote unquote any use, they had lived their life and there was little else to do. So people were abandoned to die. They would usually be taken up to a mountain and left there to die. There is the Heruli, the Germanic tribe, who used to stab older people on a pyre of wood because they felt at that point in time the life had come to an end and there wasn't anything meaningful that they could do. Now, again, if you go from Europe, let's go down to North Americas. If you look at the Inuit in Canada and in North America, they would abandon older people in the cold. So you would die of hypothermia, right? Which is very interesting in terms of the recognition that life-sustaining therapies are no longer going to be of any use. When we look at other issues, for example, when you look at issues to do with subsistence, what if this was a very wealthy family? Would they have done that? Interestingly, we talk about King George, right? Extremely wealthy, but they were suffering. What if this was to happen in other families that were wealthy at that point in time? Would they have supported it? We don't really see that because we assume because you have money, you're able to live a better quality of life because you have better treatments. But look at a place like Sardinia. What they would do is when people were getting older, after quote unquote consent, they were bludgeoned to death with a mallet at the back of the head. Now, it seems really interesting that someone can give consent to be beaten to death. And it's a scary concept. But this is what happened. In Greece, when there was scarcity of food, they actually had a debate in parliament and they agreed that people above the age of 60 had to consume hemlock. Now, the interesting thing is, and I was reflecting on whether people were 59 years old or 57 years old, and they were thinking, I'm going to pass a judgment now that a year from now, I'm going to be asked to have hemlock. So it's fascinating to see how human beings make decisions at periods of time. And when you look back now, 60 years is very young. I mean, most of the people you find right now doing amazing work are 60, 65, 68. So the point is, are we looking at the value of a human being, the wisdom they bring, or are we looking at anything else? What about Sweden? And this is very interesting because we often assume that the Nordic countries were very advanced and they had a very humane way of looking at things. Now, if you look at the Nordic countries and the practice called Atastupa, which is basically the name of the mountain, this picture you will see, they take the elderly to the edge of the cliff and quote unquote, they're asked to jump or they are pushed. Now, if you look at folklore, they believe that these people actually jumped. But you know, when you stand on a cliff and you're thinking you're going to die, how many actually have the guts to do that? How brave will you be knowing that you can't really feel and you won't feel like doing that? And it's a scary thought because if you don't jump, then you're probably pushed. Now, is this a practice that is unique to North America, Europe, or is it there in India as well? And here's the fascinating thing. It is definitely there in India. It is not the first time it has happened. It's not the last time. It has happened. And there are still cases on occasions that have arisen over the last few years. And if you look at the newspapers, you will find it's illegal though. The practice was called Thalai Kuta. Okay. And here's the interesting thing. The method used to kill people was extremely scientific. And I found it fascinating when I was digging out to find out what they do. It's in the southern parts of Tamil Nadu, and it's called mercy killing. Usually when people had aged to a point where they were not able to do anything useful. So what they would do is they would give an oil bath, okay, and make the person drink tender coconut, many tender coconuts, one after the other, and then give a cold water head massage. What would happen? Hyperkalemia and seizures. Look at the amount of science that went into this. I mean, why would you think even of giving people 10 tender coconuts? Just think of it. Why would you do that? I mean, you have two, you're full. But even come to the understanding that too much tender coconut can actually cause arrhythmias and can cause death is fascinating to me. And on top of that, hypothermia. Now, when you look at the different modes of dying, one was jumping from a cliff, one was being bludgeoned in the head with a mallet, and then you're looking at giving someone tender coconut and causing hypothermia. It goes to show you that the human mind has such an incredible ability to process information, to digest information, and to come up with solutions, quote unquote, to effect human death. And to do it in a manner in which it is from within and not from without. It is fascinating. It is still illegal, but in many cases, it's not reported to the police for obvious reasons. More men are often subjected to this than women because apparently women are more useful even in old age, which is interesting. When you talk about gender bias, one should often reflect on why it is that men are not very useful. So if you look at the more contemporary state of things, in 1828, the first anti-euthanasia law was passed. So basically, issues were coming up and people were requesting to be killed. Initially New York State, and then others followed suit. And the reason I'm reflecting on North America and Europe is this is where most of the growth of euthanasia has taken place. Not in China, not in India, not in the East. This is usually where it has taken place. Switzerland allowed physician-assisted suicide in 1937. So in 1936 in UK, we saw King George, and 1937, it was legalized in Switzerland. In 1938, there was a society called the Euthanasia Society. And by 1977, living wills were in effect. So here's the interesting thing. Because there was a law against euthanasia, people had to come up with another mechanism by which they can demand that they be killed or not resuscitated. And this is where the living wills come in. And this is where Nikhilesh is going to really help us in recognizing the role of a living will. And it's extremely important because the last thing you want is to be put in a ventilator, intubated, if that's not something you want. And living wills actually have legal weight. In 1994, in Oregon, there was the act called the Death with Dignity Act. This, again, was based on how much time you had to live. And you and I know it's very, very hard to predict exactly how long a person will live. So they had the 6-month clause. In 2002, in Netherlands and Belgium, they started decriminalizing euthanasia, allowing physician-assisted suicide. In 2016, it became legal in Canada. In 2018, in India, there were some major rulings based on the Aruna Shonbao case. In Canada, we had a bill that amended the criminal code to look at how they can incorporate this so that if someone does end up asking for euthanasia, the person who facilitates it is not charged with culpable murder, not charged with manslaughter. So how did they start weaving around this? Because very, very contentious. So if you look at some of the reason I've put this criteria here is to help us understand the thinking here so that when it comes to India, or if it does become an issue there, we know some of the patterns that have been followed. The first is they have to be eligible, right? There has to be a period of waiting. You have to look at whether the health is improving. These services are funded by the government of Canada. So it's not like you have to pay out of pocket. This is funded. We need to know that there's an age criteria. But if you look at other countries in Europe, there is no real age criteria. Canada, they're saying 18 and above. We also recognize the need for grievous and irremediable medical condition, which means there's no cure. There's no potential hope for treatment. They have made a voluntary request. And this is extremely important because it has to be from the patient. The patient has to be the one requesting medical dying, and not because of coercion. I was presenting in Florida, and I think Professor Mohandas was also there. And I was presenting about a hypothetical situation where there will be preferential insurance companies actually saying that, you know what, it's better that you opt for euthanasia than the treatment. And I put this hypothetically, and the person who was the chair stopped me and said, actually, it's not hypothetical. It actually happened in the US. So what they did in the US was an insurance company, when a patient with multiple sclerosis approached them for treatment, they said, if you go for euthanasia, we'll pay for it. Fascinating, isn't it? The patient did not ask for it. So when a patient comes in, we do not ask them, do you want to die by euthanasia? It has to be from the patient, the request. And they have to give informed consent. Two areas that again and again will come up as we discuss. So what does the public say about all this? What was the notion about, is this correct or is it not correct? So in 2013, about 65% said no. Within 4 years, 73.5% said yes. But we all know polls can be biased because sometimes they sample people who are going to give you a response. In India, when you look at the study done, so Dr. Sinha has done, VK Sinha has done, published, and they did the survey as well. They looked at the CIP survey and they found 55% in favor. A survey that was done in erstwhile Bombay in 1990, they said 78% said they would support it if there's terminal illness, but only 65 said they would withdraw life support. So it shows that even though people do support it, when it comes to pushing for, yes, let the person die, it's a very difficult ethical issue. So what about the death rate? Just because you have euthanasia, is everybody jumping in for it? Interestingly, in Canada, the rates are much higher than I've seen in other countries, and I don't know why. So if you look at the rates that in 2016, after it was legalized, it was 2.5%. It's gone up to 3.3%. And now there is a move to make it legal even for mental health issues. And this is where it becomes very difficult for us as psychiatrists, because you're thinking, how can a depressed patient make a decision about euthanasia? Maybe they haven't tried all the treatments possible, right? So we can see that the numbers in some countries have gone up. In other countries, it has gone down. Now, we were talking about the whole notion of euthanasia, right? We spoke about how it happened centuries ago. We spoke about how it happened with King George, but there's also precedence with the Roman emperors when they did not want to die a painful death and they could opt for an easier way to die. So essentially, what the concept was that people would just walk into the sun, right? So we spoke about the legal issues. We spoke about areas around walking into the sun. We can't really do that these days. You can't really walk into the sun. You can't abandon someone on a hilltop. You cannot push someone over a cliff. You cannot give them hemlock. You cannot take a hammer and smash their head. So they're looking at ways in which you can approach it from a more quote unquote humane way. So the term was used by Francis Bacon, basically to imply painless death. And it alluded to the physician's duty to alleviate suffering. And this is very important, very, very important, because on the one hand, we should not cause death. On the other hand, we're trying to alleviate suffering. And this becomes very challenging because you're beginning to think, what exactly are we doing here? So when we look at the notion of alleviating suffering, it becomes important for us to validate what it is that we recognize the patient is requesting as well. Now, if you look at during the time of the Nazis, the whole movement towards killing people who were disabled or intellectually impaired, mentally challenged, this concept came about with the request of a German boy who was very unwell. And if you can look this article up, the link is there. It's a very interesting story to read. But this actually gave rise to the movement of eliminating people they thought was inferior. And it's a very, very strong socio-political construct because you can use it to justify acts of intense cruelty and genocide by saying that this is something that can be done because another group is inferior. It's very interesting. So I would advise you to read this article because it is very, very eye-opening. And to me, it spoke volumes to how we actually approach one another. So what are the predominant reasons for euthanasia being requested? Obviously, terminal conditions, multiple sclerosis, amyotrophic lateral sclerosis, patient with cancer and chronic pain, patients who are unlikely to recover from it, who want to die. But then on the other hand, you have people who are extremely intelligent with conditions like this, who want to live as well, right? So we don't know whether there's an inherent lack of resilience. It was the whole sense of futility, assuming that I'm never going to get better, and conditions like this we know do not automatically transform itself and patient is cured. But where do we pitch ourselves as psychiatrists? So in Canada, we've had a number of legal challenges. Key ones are Carter versus Canada. And the medical assistance in dying, as it is called here, is a right for a competent, consenting adult with a grievous, irremediable illness, disease, or disability, causing enduring suffering that is intolerable to the individual. It's a beautiful definition. It encompasses so many things, but it highlights each of those components over and over again. Competency, consent, grievous, irremediable, disease or disability. So it's not just a disease, it is a disability as well. So what if it's a person who is born with a disability, who after 15, 20 years says, I can no longer live with that? Now, the parameters given do not limit MAID access to only those who are at the end of their life. So do you remember we saw the thing about 6 months to live, and that was a criteria? Now they're doing away with that because sometimes you cannot foresee what the person's illness trajectory is going to be. I won't go into Canadian law in detail because it's more relevant for us to look at the Indian law, but to reflect on what is going on, they talk about people having a serious incurable disease, a disability, advanced state of decline, and then the illness or the state of decline causing them incredible physical, and see how the thing has changed, psychological suffering. So we went from the physical parameters to psychological suffering. I can no longer put up with this. So basically, they spoke about certain important things, including the nature of death. The natural death has become, reasonably, you can see the person is going to die. Why do you want to protract the suffering? The medical circumstances without a prognosis having been made, it's only a matter of time, opting for euthanasia. So in the Netherlands, there was a very interesting case where a woman had opted to die, and when the son came in, the patient was having cognitive impairment. So the illness started, the patient said, if I have Alzheimer's dementia advanced, please take my life. But when the patient was in the advanced stages of dementia and the son came and said, do you want to die? The patient said, no, I don't want to die. I want to live. But the doctor went ahead with it. So there's been a slight slowing down with malpractice lawsuits that came up, and it puts us in a very awkward position because you have to realize the whole issue about consent capacity. So a decision has to be taken at the time to discontinue life support, either by the parents or the spouse. And this is more the context within India. And Nikhilesh will give us more ideas into this. But it talks about how a group of people can act as the friend, or an individual, if they don't have any family, somebody, a group who can actually act on their behalf. But even then, a request has to be made. You have to get approval from the High Court. So if you look at the IPC, the cases of involuntary, non-voluntary euthanasia, it would be cancelled out by the first proviso, which talks about medical negligence, okay, and consider this act to be illegal. So this is very important because here in Canada, they changed the criminal code so that that would not be seen as being illegal. So there are still things within the law in India which still make it illegal. So the union government has given a decision to decriminalize suicide. It is to be noted that all cases under Section 309, which denote suicide as a crime, are disorganized, often screening the crime of abetment to suicide. So we'll have to have help here navigating this language. And so I'm glad we have an expert with us. But it is undeniably illegal. Okay, it is still not legal in India. But if you look at the Aruna Shambhav case, what happened there? It's the difference between active suicide and passive suicide. And this is an important concept for us to understand. So on the 7th of March 2011, the Supreme Court of India legalized passive euthanasia by means of withdrawal of life support to a patient in a permanent vegetative state. Okay. So then you look at how issues came about with regard to validating, but we haven't had that kind of a discussion because it still is a taboo topic. It is a very difficult area for any one of us to approach. I struggle with the concept of it because we still see patients who are requesting euthanasia, and we have to make sure they don't have clinical depression. I had a patient who was admitted to my unit who later on successfully asked for MAID. The patient was having severe depression, had made a severe suicide attempt, but survived. And when I asked him about dying, the basic premise was, I've had a good life, doctor. My breathing is not going to get any better. I want to die. I'm not depressed. If you could cure my illness, I want to live. But you cannot cure my illness for me, can you? So it is a very difficult discussion to have with the patient. But there are the other conditions as well. Someone with severe conversion disorder. And this is a quote. She suffers from involuntary muscle spasms that radiate from the face, through the sides and the top of her head, into her shoulders, causing her severe and constant pain and migraine. Her eyelid muscles have spasmed shut, rendering her effectively blind. Her digestive system is ineffective, and she goes without eating for up to 2 days. She has significant trouble sleeping, and because of digestive problems, she's lost severe amounts of weight and muscle mass. She's non-ambulatory and needs to be carried or use a wheelchair. Her quality of life is non-existent. I mean, it is so descriptive. It paints a picture of hopelessness. But here's the issue. Is there anything we can do to effectively treat a conversion disorder? Has she had access to good psychiatrists? In Canada, access to mental health care is extremely difficult. There are people who cannot access healthcare, have to wait for a year, 2 years. But we do have a system in place. You can go to the ER. What if the patient sees people who repeatedly are not capable of rendering extremely good mental health care or don't have access to things like ECT? I'm just giving you an example because it's a huge country here. You go to places where there is no ECT. Now, would ECT have reversed the patient's severe depression? Possibly. What if the patient was on the wrong combination of medication? What if the patient has not seen a psychiatrist but is being managed by the family physician? What happens then? What if this patient had never seen a psychiatrist? So the problem here is the moment you bring mental health inside, it makes it even more complicated. So the argument made was that why should a patient with mental health condition be discriminated against? So this was the argument. So the description that you look at with the lady before appears neurological. But as with all things with neurology, when they don't have an answer, it becomes psychiatric. The point I'm trying to make is sometimes it's very hard for us to distinguish between the two, and we're often in a difficult position, and we have to make decisions. And this is when euthanasia is not legal in India. Imagine if we get to the point we have the discussion, how much of extra work as psychiatrists we would have, not just ethically, but medically to deal with. So what are the challenging areas that will come about in the next few years? Eating disorders, financial difficulties. People are in debt. What if I come and tell you, doctor, in the foreseeable future, I cannot reverse my debt, a debt I don't want to live? Would that be a good enough reason for euthanasia? What about elder abuse? I cannot take the suffering for my children anymore. I've had enough, doc. I've had a good life. I want to die. What about organ harvesting? We think, there are so many people with kidney problems. What if we should be doing organ harvesting? They've had a good quality of life. They want to die. What if they start suggesting to patients, you've had a good quality of life. Don't you think you should move on and give your kidney to other people? It's a very slippery slope. What if governments start giving incentives? Like the insurance company said, we'll pay for euthanasia, but we won't pay for MS treatment. What if government starts saying, you know what, we will take care of your family, you can opt for euthanasia? Then what? What if it takes 4 years to get placement into a long-term care facility? Here in Canada, it takes a long time to get placement into long-term care. What happens then? So what do we use for euthanasia? I won't go into too much detail. What I'm trying to explain is basically that there are certain techniques you can use, medication combinations that you can use, from pacuronium to lorazepam, and I have a slide that I can send if people are interested. But those are different medications you can use to suppress respiration to cause death. Okay? Key elements of consent: it should be voluntary, patients should have decisional capacity, and they should be properly informed. These are the list of medications. I will not go into details here because I think what we need to be having is more of a discussion. You can see even propofol is there at much higher doses, diazepam. I'm sure if you talk to Bhaskar will have patients who are on higher doses of benzodiazepines for very good reasons. But the point is they're using benzodiazepines also to facilitate or to come about with causing euthanasia. The other issue here is whether people will start exploiting this. And like anything in life, where there is a business opportunity, people will do it. And I often wonder if we are not careful with laws, whether foreign citizens can come to India and ask for euthanasia. And I wonder whether this will open up and this will become a hotspot for euthanasia. I'm just throwing it out there. I do not foresee it in the immediate future, but I'm wondering whether this could be one of those things that do happen. Because if you look at Switzerland, and this I took this from the newspaper, The Guardian, if you look at the numbers going up, the numbers are definitely rising, right? And you can see the difference between foreign residents and Swiss residents. you can see the number of Swiss residents is going up, but there's also a number of non-Swiss residents. So what if India makes it permissible that people can seek medical treatment, and within medical treatment, alleviating suffering is one of the key objectives? Then what? Now, I'm going to end with this quote. You know, it looks beautiful when you look from here, right? And there are people walking, there's a person sitting there. I don't know what their life story is. I don't know how much they're suffering. But from here, everything seems to be fine. We can make laws to help regulate things down there. But is it going to be truly effective, honest, just, and what the patient needs? With that, I end my presentation. I'm happy to get Nikki's perspective, but over to you, the chairperson. Thank you.
Thank you, sir. I think we can invite Nikhilesh ji.
Yeah.
Sir, please unmute.
Sorry. Thank you, Dr. Shabir, Dr. Matka, for inviting me here on this topic. I mean, it's more an invigorating topic because this has such ramification in the present context that it has a prone that it could be misused and it can be used in the right direction, because that's where the legal perspective has actually understood all this while. It is not as though that euthanasia is not recognized by the courts or anywhere in the world. If it is required, it is required. But it depends on what circumstances and in what condition. In fact, the two subjects which is quite key is the patient and the other is the physician, in my view, because patient definitely would like to elevate his suffering in a position when he is actually ill and he knows that he is going to see the death anytime, and his medication, his treatment is not helping in any manner to alleviate his suffering or the pain. But most importantly, what the courts have recognized, and that too in India, is the importance of the physician who has to give such an advice. I mean, if he gives an advice and he gives it with some tremendous responsibility, for the reason being that he has, I mean, gone against the Hippocratic oath, possibly, and also to the extent to do something which he would at some point of time reflect that it is going to, whether such a decision was lawful or not, whether it was morally correct, ethically correct, whether he will be able to sleep over it. And that's the most important part, where I believe the mental being of a doctor is going to be affected. I feel, in my view, I mean, subject to correction if the panelists feel some other issues are there. I'm happy to hear such suggestions too. Coming back to the genesis of this particular issue in the courts in India, especially in Supreme Court, came up on an analysis of a Swedes Act along with the euthanasia being equated, not at least equated, but to be compared whether right to die exists in a person as a fundamental right. Our constitution provides with several fundamental rights: right to speech, right to have a profession, right to have clean life, clean air. So many rights are protected. But most important is right to life. And the courts have gone to the extent of saying right to life means right to live with dignity. Now, this word dignity has got a big I mean, I don't think there is any definition for that. It is an unqualified word and can extend to any kind of context. And the word human dignity has much more to offer in every context. The courts cannot define it. It comes with this kind of situation you are put in, whether this human dignity will be at some point of time when he's at the ripe age of his earning time, maybe in the mid when he is looking after the society, maybe at the end when he is just about to renounce everything and possibly look to a retired life and not doing much. So these are the ages and these are the phases of a human life where dignity comes into play every time. And possibly the courts have only interpreted that dignity is a fundamental facet for to live life in a happy or a joy. I mean, the way he wants to. Now, this is most important. A person who wants to live his life, the power of self-determination, the power that, yes, he is in full control of his life. That's the most important factor, even for euthanasia. When euthanasia is brought about as a subject, he should be aware that, yes, I have the power to determine whether I can leave this world or not. So that's the most fundamental thing for him to say that I have prepared a particular, I don't consider, now the courts have said it is not anymore to be coined as living will. You say it's an advanced medical directive. So this directive, which I proclaim that I would like to say that when I want to leave this world, I think that is a fundamental thing which has to be understood in what manner he can bring it about. Now, courts have gone all through what the start of, I mean, the most important case which came about before the Supreme Court was the Aruna Shanbag case. I think most of the people know about it, that a person, a nurse, who was subjected to a particular sexual assault, and then she was chained and had suffered a brain damage and was in a vegetative state. She was there for 36 years till the time somebody, a friend of hers or a friend known to her, filed a petition to the Supreme Court saying that let her go peacefully. Stop the feed. Stop the feed, let her go peacefully. However, the courts in India do not have that heart, I would say, that yes, we could say somebody could go just by saying, yes, I want to go. I don't think so. Morally, ethically, and even consciously, the courts are in such a power to say that yes, right to live is right to die. I think that has been very clearly laid down, and now, as part of the judgment of various pronouncement, it has come to say that right to live means only to the extent right to live with human dignity. Now, keeping that in mind, that is how the pronouncement has come to a stage where they say that yes, keeping in line with most of the countries, we have yet to make out a legislation by the legislature saying that yes, euthanasia will be part of the system whereby a person can choose to renounce his life or choose to say that I have a right to die. I think it will never come because this is prone to misuse. There are instances which has happened, or maybe people have understood. We are not evolved to that level that we can say, yes, I will make a will, that I will choose to lay down my life, or maybe I would like to die in such circumstances. But it could happen that that particular instrument may be misused by somebody who want to profit from whatever I have, or maybe in some manner. So this has been at the back of the mind of the Supreme Court, that we do not want to venture and say that we will direct that there could be a legislation. It only said that yes, there could be some form in a particular situation to bring about an alleviation of pain and suffering to only those people who are undergoing a particular treatment or a illness which is incurable, irremediable. And now, irremediable is only the Canadian courts who have coined, I mean, like Dr. Shabir put it. But illness which is incurable, and he knows that death is inevitable. Now, if death is inevitable and the delay of the modern technology does not help is alleviation of this pain, suffering, then the dignity to live a proper life comes to be affected. And that's where the only criteria what the court said, yes, we recognize such a situation, then a person are in two positions. One, if he is conscious, if he has got the sound mind and capacity, he may make this directive and keep it ready in the eventuality of such a situation that he is unable to live a life with dignity. Now, there are several safeguards. Whatever safeguards which the Canadian courts have held in the case of Carter has been more or less taken as a leaf for us in the 2018 Common Cause judgment, where they came with the directives how to make an administrative or advanced medical directive. Now, this is one it is in place against a living will. I mean, I would say living will was not appreciated as a particular term, and they replaced it saying that it should be treated as advanced medical directive. Now, this is only to facilitate the fructification of a sacrosanct right to live with dignity. That's what the courts phrased and laid emphasis about. And while they laid down the emphasis, they also said there should be certain parameters, how it is to be made, how it should be, whom it should be kept with, all that fundamentals, along with the safeguard that it should not be misused. That was the basic foundation which this particular directive, by this judgment, it was given. I mean, it's a very elaborate particular directive along with the directives which the Supreme Court has given how to make that particular instrument. In fact, I can share that particular document in the judgment, which I have it with me. I'll just share it with you. It's very interesting because that gives the insight about that particular how the courts have framed it out. Just give me a moment. I'm sorry, give me a minute. I'll just come back with the slide or the screen which I have in hand. It's in the case of Common Cause.
Nikki, there was one question by Professor Isaac in there. While you're pulling that out, do you mind if I answer that question?
Yes, please do.
This was so Professor Isaac is basically asking about patients in advanced stages of Alzheimer's on palliative care. So we've had this discussion here, and it becomes very difficult unless you have a living will. So if there's no living will and the individual doesn't have the capacity to make those decisions, it becomes very difficult because then you have to rely on the power of attorney or the substitute decision maker. So the problems we have gotten into is when there are issues of elder abuse, like Nikki basically said, when there is a vested interest in wanting the person to pass away. So there's a Malayalam movie, Pattagada. There are 10 stories in which a guy takes his mother for a movie and leaves the mother at the movie in the hall. It becomes very difficult because we really don't know where it's coming from. But if it is very clear and the substitute decision maker can make a decision on behalf, then usually we go ahead with addressing possibilities. But in my entire experience in geriatric psychiatry here, we've not had a single case that came to that. Sorry, Nikki, back to you.
No, absolutely fine, Dr. Shabir. I'm sorry I could not pull out that particular slide over here or share the particular judgment in front of, but I just read out what are the essentials basically. it started, the Supreme Court started with the enumeration of how to make the advance directive. First of all, who can execute? Advance directive can be executed by an adult who's of a sound and healthy state of mind and in a position to communicate, relate, and comprehend the purpose and consequences of executing the document. Now, this is very essential. Somebody who knows that, yes, there would be a situation which he might have to undergo pain, anguish, suffering, and he has some feeling, understanding that, yes, he may not be able to alleviate his suffering and death is imminent. Such kind of understanding of a person, an individual, should be there before he makes such a directive or such kind of document. Now, that's very important, key. Then it must be voluntary, executed without any coercion. Now, this is also very important. This is enjoins the first part, that yes, once he knows that there is a problem which he might suffer, and then he has the understanding, so therefore it will be done voluntarily. It will not be done under any forced coercion, because that's very important. Sometimes what happens, some of the people are influenced with, maybe with organ donation or some other kind of influences which would be given to the patient or the person, that he would be coerced into making such a will. So that should be free of it. Thirdly, it should have characteristics of an informed consent given without any undue influence or constraint. Maybe similar, but informed consent. Therefore, the consequences what he is going to undergo, he should be informed. So therefore, that information that he understands this would come at some point of time, and therefore I am giving this consent, is also essential. Then comes, it shall be in writing clearly that as to when medical treatment may be withdrawn, or no specific medical treatment shall be given, which will only have the effect of delaying the process of death that may otherwise cause him or her the pain, anguish, and suffering, and further put him in a state of indignity. This is the most key essential part. You are talking about right to live with dignity. So therefore, once he understands that now at a stage where I can't live with dignity, therefore I am making this instrument is most key. So these are the fundamentals for a person who makes the executed. Now, what it should contain apart from this, that it should clearly indicate that this decision relating to circumstances in which withholding or withdrawal of medical treatment can be resorted to. So that's also important, that yes, I do not withhold or I do not have the medical treatment which I would not resort to. Then it should be in specific terms and instruction then it should be in specific terms and the instruction must be clear and ambiguous. Yes, that I do not want to continue further. It should disclose the executor has understood the consequences of executing such a document. It should specify the name of a guardian or a close relative who, in the event of the executor becoming incapable of taking decision at the relevant time, will be authorized to give the consent to refuse or withdraw medical treatment in such a manner consistent with the advance directive. This is very essential, because it is always a stage where at some point of time he would not be in a conscious state of mind that where he could give consent to withdrawal of a treatment. And in the event there is more than one valid advance directive, none of them has been revoked, the most recently signed advance directive will be considered as the last expression of the patient's wishes and will be given effect to it. So these are the legal parameters which go into the making of the advance directive. Now, apart from that, the court also laid down the process in what manner this could be executed, that it should be gone to a notarized officer and then it could be signed by two witnesses in front of them. All that legal formalities have been given. But key essential is this particular ingredient that yes, it should come voluntarily from the person who makes such a directive. And lastly, but not the least, most important is that keeping this particular document. Now, this document can be with the person who is the person who has been named as a guardian or a relative. Apart from that, it is also being provided that it could be referred to the municipal corporation and then given it to their. So it has got a very similar criteria what happens in executing a normal will. A normal will when you give inheritance to. So when you make a will, you normally provide that this is my property and in my free will, I'm giving it to such a person and this is signed by me. And now it is being signed by 2 witnesses. They are signing in front of me and therefore they recognize my signatures and everything, the content thereof. So, and such a will cannot be challenged on the ground that the will is not correct. So all that essential ingredients, which is more akin to this particular directive, is very similar, but it has got more bigger, I would say, ramification and a different dimension and a different way where it goes into, especially into the right to die as is concerned. Now comes the part when what happens to people who are terminally ill. There the courts have gone into the aspect of that in the event the executor becomes terminally ill and is undergoing prolonged medical treatment with no hope of recovery and the cure of the ailment, the treating physician, when made aware about the advance directive, shall ascertain the genuineness and authenticity thereof from the concerned officer. I mean, it could be, it was earlier a judicial magistrate, now it has been changed to a notarial officer or a corporation where it is presented to. There's some slight modification which was done in the year 2023 after being pointed out by the experts in the field and as well as the law officers of the court that it's very difficult to make this particular judicial magistrate accountable or maybe bringing him every point when you want to process with the entire execution of the will or maybe, placing it in somebody's hand. So they said this entire directive can be with a custodian or a particular person whom the person wants to delegate it upon, like I can give it to a friend or a person who's near relative or somebody who's even I have a confidence that he will retain such a will. So more importantly is to assign it to a person. That is more. But key element is that if a person is terminally ill, then the advance directive will give the guidelines regarding the entire aspect, how to deal with such a patient. Then the instructions in the document must be given due weight by the doctors. However, it should be given effect to only after being fully satisfied that the executor is terminally ill and is undergoing prolonged treatment or is surviving on life support and that the illness of the executor is incurable or there is no hope of him or her being cured. Now, this is very fundamental. Now, this is where the doctors have a bigger role to play when they say, yes, he is terminally ill, but he is incurable. I do not know whether most of the doctors would be in a position to say such a thing. And I mean, this is something, it's my personal view. Apart from that, what the law has been laid down, possibly this is only to benefit the person who is terminally ill. Then comes, and that too, he is not in a position to ascertain what his position is all about. Then comes the issue, if the physician treating the patient, that is the executor of the document, is satisfied that the instruction given in the document need to be acted upon, he shall inform the executor or his guardian, close relative, as the case may be, about the nature of illness, the availability of medical care, and consequences of alternate forms of treatment, and consequences of remaining untreated. So that's very fundamental. He must also ensure that he believes on reasonable grounds that the person in question understands the information provided, has cogitated over the option, and has come to a firm view that the option of withdrawal or refusal is the best choice. I mean, the best choice, this particular phrase is something, I mean, I have to feel that if the conscious has to bring in such a factor that yes, this is the best choice. I do not know how it can be acted upon, but obviously this is one of the fundamentals of the particular action of a physician. Now, thereafter, the physician hospital where the executor has been admitted for medical treatment shall then constitute a medical board consisting of the head of the treating department and at least 3 experts from the fields of general medicine, cardiology, neurology, nephrology, psychiatry, or oncology with experience in critical care and with overall standing in the medical profession of at least 20 years, who in turn shall visit the patient in the presence of his guardian or close relative and form an opinion whether to certify or not to certify, carrying out the instruction of withdrawal or refusal of further medical treatment. This decision shall be regarded as the preliminary opinion. Now, therefore, this at least saves this issue that it is a concerted effort from all the department concerned to come to some opinion. Yes, the patient has formed a particular situation where he may be given a process of maybe ending his life. Then thereafter, in the event hospital medical board certifies that the instruction contained in the advance directive ought to be carried out, the physician hospital shall forthwith inform the jurisdictional corrector about the proposal. The jurisdictional corrector shall immediately constitute a medical board comprising the chief medical officer of the district as the chairman, 3 expert documents from the fields of general medicine, cardiology, neurology, nephrology, psychiatry, and oncology with experience of critical with overall standing of 20 years. They shall jointly visit the hospital where the patient is admitted and if they concur with the initial decision of the medical board they may endorse the certificate to carry on the instructions given in the directive. So therefore, another check and balance to see that whether the preliminary opinion is in line with the actual situation of the patient who's actually requested for such a particular process. Then thereafter, the board constituted by the collector must beforehand ascertain the wishes of the executor if he is in a position to communicate and is capable of understanding the consequences of withdrawal of medical treatment. And that's another step towards confirming whether this is required or not, or whether the person is really, in a position, is such a person that he is going to undergo the aspect that there is no hope in the medical treatment. In the event the executor is incapable of taking a decision or develops impaired decision-making capacity, then the consent of the guardian nominated by the executor in the advance directive should be obtained regarding refusal or withdrawal of medical treatment to the executor to the extent of and consistent with the clear instructions given in the advance directive. So there is another step, which actually holds that particular decision, whether to give or not to give, with the person who's been appointed by the executor, that yes, whether to give consent or not. But then again, the consent will be in such a manner that if there is any hope that there is a recovery by such a person, I feel, and that's my personal view, because again, a nominated nominated guardian or a person who's a next kin or friend would like to see the benefit of his friend, obviously. So therefore, again, at least he has the power to say whether he is, the right decision can be taken in favor of the executor. That apart, Yeah,
There's one very interesting thing that was posted in the group.
yes.
The question was, there is this notion of sannyas, right? Where people, you prepare for death, isn't it?
Jainism. In Jainism
Yeah.
or some forms
So in
of.
Jainism, it is there as well, you stop eating. But sannyas is different. No? You're preparing for the stage of death in a different
Correct,
way.
correct.
You're not seeking death, you're preparing for death.
Yes.
How would the courts look into it? For example, if I say tomorrow, I don't want to live. I've had a good life. I'm thinking maybe I should just walk away. Can the police stop me and say, people, your family is saying you're not eating food. You're going to you're suicidal. Will they arrest me?
No, there is no power in such with the police as such. In fact, police will not get into any of those situations so as to say that you are renouncing the world. Renouncing is acknowledged by the law. I mean, in laws of Hindu, when you renounce the world, you give away everything, including your proprietary rights, even in property or whatever. So that's been recognized by the courts as well. But renouncing the life is yet to be. I mean, courts have steered clear from such kind of situations. They have only gone into the aspect of where the subject is undergoing treatment and is not in a position to take a decision. I mean, he wants to live the life with dignity. And that's where the courts have embarked upon going into the aspect as whether the person should be given the right to die, die with human dignity. That's the only thing which the courts have gone into. And that's the only reason why they have come with these directives. Otherwise, legislation is not there. So therefore, it is illegal. Like for other countries, there is legislation which permits such a active or a passive euthanasia. In India, it is not so. Even to the extent that yes, suicide is also not to be treated as illegal. Suicide is never to be treated as legal. So that's why courts are very, very reluctant to say yes, euthanasia is legal. And it's got larger ramification because of the society. Multiple factors are there. Which has got.
Sir, in the interest of time, can we take a few questions? Because I think Dr. Shabir has to leave early also.
Oh, I'm sure. Yes, I think I have closed more or less, I wanted to only highlight that the courts have only come now to the stage of, in the absence of any law, they have passed this judgment to bring about advanced medical directive in place of living will. So that's very key right now for this particular subject.
Thank you, sir. If Chairperson is allowed, 2 quick comments, one from Dr. Mohandas, then from Dr. Mohan Isaac. Mohandas, sir, please.
Yeah, I heard Shabir, he's a friend of mine. He spoke very well. And I heard the lawyer. And basically, you have to take into consideration of 2011 Shabanu case and 2014. It was referred to the 5 judges, but nothing has come out. So it goes to, in bioethical principles, there's a term called futile medical intervention. Medical futility, it can be quantitative or qualitative, which was approved in 1999, Texas, especially Advanced Directive Act. That is what our lawyer has told, especially Advanced Medical Directive. I will not discuss more. Side by side, you have to also know another principle called principle of double effect. US Supreme Court has agreed to that. I will not elaborate it. There is another one, a principle of double effect has really come from Thomas Aquinas, Summa Theologica. Then lastly, there's something called a defense of necessity and Sir James Stephen's criteria. I will not go into details. There are the thing. Anyway, in India, though initially it was passive, euthanasia was suggested, but the client has got the right to life, and beautifully, the Texas Advanced Directive Guidelines has already given as the lawyer has told, I think we cannot do more than that. And I agree with our Shabir's suggestions also. Very intricate topic, because the conflict resolution in this type of thing is advanced directive, the informed consent, the autonomy, etc., that he has told. I will not elaborate. Thank you very much. It was wonderful session.
Thank you, sir. Mohan Isaac, sir, please.
Thank you, Alim. Thank you very much, Shabir. It was, as always, a great pleasure to listen to you. The topic, of course, as you have simplified, is a very complex topic, but you've done an excellent job to a very difficult topic with your vast experience in Canada in the field of geriatric psychiatry, made it relevant to an Indian audience where things are very different. The issues are universal, as you again and again pointed out during your presentation. This is not anything very new, as you rightly pointed out. It has been there historically for hundreds and thousands of years, but it continues to be a very, very complex and sensitive issue, and you have made it simpler. The question that I asked in the chat box is about people who are terminally ill, not terminally ill like a person with a terminal cancer, but the terminal Alzheimer's, where you have lost most of your functions, your bodily functions, including your, maybe swallowing ability because there is choking and various things. So you can't give consent. You don't have capacity. You're dependent. You are on life support systems. Now, how do you deal with that? Of course, is assisted suicide has any role at all in such a setting? These were some of my thoughts which came up in my mind as I listened to you. How are things? Also, I must tell you that you showed that global map about where it is legal, not legal, etc. And Australia, of course, it was all completely blue, except one chunk, that is the Northern Territory. But what is most interesting is, historically, it was Northern Territory in Australia which legalized assisted dying as early as some 20 years ago. But its parliament, after a great debate, took it off. Subsequently, various other states, one by one, New South Wales, Victoria, Western Australia, etc., brought it on. But within Australia, even today, New South Wales, Northern Territory still doesn't have, as your map rightly told. I just wanted to highlight that point. You may wish to comment on the issue that I raised, or you may just choose to ignore it. Thank you, Alim, for asking me to make a comment.
Thank you, sir.
Always
Thank
a delight. It's always a delight to hear your questions. They're very, very deep, and you're right. It's one of those areas where we look at capacity and the individual's ability to both process information being offered to him in terms of where the foreseeable future is with his diagnosis. We've had that, but unfortunately, fortunately or unfortunately, we got into some very difficult areas with families being very divided. You always get that. One group saying, my father should live. I don't see any reason why he should die. And you have relatives who say that, no, he is suffering. He should not really be living. That's usually when we appoint the public guardian. Now, I have not been directly involved in cases where the patient has not actually had the capacity at that point in time to decide for themselves. But currently, we've had situations on the unit where we do get into conflict situations. Often it's not to do with the patient's desire, because there's no living will. And many individuals, if we are asked at this point in time when we are healthy, cognizant, and capable, we'd most likely say, I don't want to be intubated. I don't want to be in the ICU. I'd like to die at home. The problem is we don't put pen to paper. So the patients we've had who have come in where it's become complicated often do not have a living will. If they did, this would not be an issue at all. But in the Netherlands, where there was that issue that I quoted, where a woman said, if I develop on advanced Alzheimer's, I want to die. I want you to give me the injection. When she developed advanced Alzheimer's, she changed her decision. She said, I don't want to die. And the son could not do anything. And the doctor went ahead and did what she was supposed to do. So I don't have a simple answer. I wish I did, but it's one of those areas where I feel there will be case law and people like Nikki will probably be involved. And the fundamental issue is the ability to recognize and whether you have a power of attorney who you trust to make a decision on your behalf.
Thank you, sir. Thank you, sir. I think we invite chairpersons for the comments.
Well, I strongly feel that advanced mental health directive yet not percolated in the Indian mass or people. There is no much awareness. It's high time that even advanced medical directive as a concept also needs to be floated in general medical conditions and for general medical treatment. Having said this, as far as the organ transplant is concerned in India, with the help of the Zonal Organ Transplant Committee, the things are well regulated and monitored also. Yes, there are a few cases where the abuse has taken place. There is some kind of irregularities also which have taken place. But still, it is quite a foolproof system as far as the regulations which were given by our advocate, in which the video recording, etc., is still being done very quite meticulously, and there are multiple filters to that. If in cases of terminal ill or CA or ALSMS, etc., which we consider as where passive euthanasia be taken as, I still feel that if we have a regulatory guidelines, things can work out. Not necessarily that we should have always the ethical issues, because the same ethical issues were also raised at the case of organ transplant, and now the things are much under well-regulated things. There are certain guidelines, provided these regulatory authorities are planned and given those kind of guidelines. I think to some extent this can be possible. If it is not impossible, we need to have a lot of education as far as the family is concerned, the society in general is concerned, and of course the dilemmas of the medical professionals are concerned. Thank you.
Thank you, sir.
Abhay sir?
Big thank you. I learned a lot today and still more to learn. Thanks a lot.
Amrit, some questions from the chat box, please.
Yeah, I'll pick up one comment. This is by Dr. Sabin. While being part of a community-based study on geriatric depression, I've seen elderly around 80 years old, otherwise healthy people, when asked questions about suicidal ideas as part of the questionnaire, reply that they would rather die now without developing some illness and bedridden and becoming a burden for the relatives. They say that they have lived a full life, and now would like to peacefully go to death. They did not have any features of depression, but if you just consider a yes or no response, you may think that they are depressed. This is one of the comments. I think our setup and the Western setup are a little different in terms of the social support, the people who take care of the elderly, and there is a different cultural context to the whole concept of euthanasia when it comes to Western countries and India. I think, and that context needs to be taken care of. And many times we see guardians taking off their patients and going home, telling that they will take them to another hospital and they let them go and die in the house within 24 hours. So, different things, different areas. So your comments on this, and people wanting to die rather than be a burden to others. Because we don't have elderly care facilities in a place like India. Again, that's a different thing. The social setup is a little different in this. Sir, your comments.
Things are evolving very rapidly in India. You have some extremely good elderly care facilities. It's become a business model. So my feeling is India is going to be a hot destination for retirees, where the dollar is more powerful, the pound is stronger. People will opt to come there, which is why this topic is so relevant. And that's why I feared you'll get people opting to live in India saying, if I reach the stage, I want euthanasia. So there's going to be a lot of case laws coming in, and people like Niklesh are going to be at the forefront of this stuff. But the point is, we cannot escape from it. And like Mohan Isaac was pointing out, we're going to read these areas which are so difficult because there's going to be a lack of capacity at that point in time. who is it that we're going to basically hold responsible or accountable or even to ask for a decision? And this would be someone with a US passport who's opting to live in India the last 10 years of their life. And many people are now seeking to come to India because you get more for your money. So I don't think this concept is going to disappear. However, for Indians who can't afford the care, that's a very difficult question. And I do see there are financial difficulties. Even here, people are struggling and they make the same comment. Why should I live if I know I'm going to develop an illness? I honestly don't have an easy answer for that. I really don't.
So Dr. Christina has a question. A multidisciplinary team would be needed for assessment and decision making. So what would be its composition?
Yeah, so Nikki very nicely pointed out in India, they talk about how you have to have a team of people, including cardiologists, who come on board. Here, we really have basically, you need to get the opinion of 2 other physicians. It can be a nurse practitioner as well. They come in and speak to the patient, but there really isn't this notion of having a very dedicated, specific, multidisciplinary team. You have people who will do MAID consultations. So that is the group that they have. But I think it's a great idea. You have you have like a priest available, you have the oncologist, you have the family members. I think that would be a fabulous way to go ahead.
So any comments on the Jain practice of Santhara?
It's an old concept. It's not new if you look at it. And within Jainism, it's a thing about you not being a burden on anyone, right? And you're basically refusing food. And we know many people who do that. They refuse food and they die. Some people do that out as a political statement. Some people do that out of adversity. But many people do that because they've had a good life and they think, you know what, maybe this is what I want to do. For as long as there's no clinical depression, which is why it's usually good to get a second opinion if someone is holding off on food.
Can I make one point over here?
Yes, sir.
This subject, I think, would be more relevant in a situation where the medical profession is brought about into a picture, where the person is choosing to opt for, I want to die. Because renouncing life in different parts of our religion was never touched upon by any of the courts in any of the judgments. They kept it aside because that's an individual choice without any circumstances of such kind. I mean, it was voluntary nature of the situation, everything put together. But here, what we are specifically dealing is a patient who's going through a particular patch of treatment and is not able to recover. Then the onus actually shifts to the doctor, majorly. And I believe most of the part of this judgment actually focuses a little bit on the doctor when he has to assist such a decision. And I believe that's more, very vital, where the doctor is faced with a position that he has to take a decision along with the others to say, yes, you are not going to come out of this position, that you may not get cured anytime, and it's better that you go peacefully, which is at a later stage, he may take a decision at that point of time along with the multidisciplinary team and everything. But I do not know how many doctors could sleep after this decision is made when he has to go against the Hippocratic oath. And I believe most of the doctors are all conscientious people and have a clear conscience at some point of time to come to a decision. This is most fundamental. I do not know how the doctors feel about it and how do they have actually worked upon it.
Nikhil sir, you said in your presentation that this law is never going to come to India. Why do you think so?
It's actually public policy. Now we have to see our entire country, the social fabric, the people who are involved, the system of education, the level of awareness, even to the basic right. For a franchise right, we're not seeing that kind of levels of people coming and involving themselves. Can you imagine what this kind of law would come in and have ramification with the misuse? It could have such kind of effect. Very, very devastating effect in my view, because it's my personal view. I feel, people may agree, may not agree, but I still feel that a lot of people cannot accept this fact. Yes, somebody has made a will and I will see to it that he goes away and all that what he has got, I can appropriate it, even to his organs. So there can be situations, multifarious issues, that if this law comes up and we don't have a proper system to take care of it, we will be nowhere. We still are grappling with the issue how to go about with the system. We just started with the baby step of bringing this advanced medical directive. But there are miles to go before you come to a level that yes, you have to execute such a thing and put into actual practice, which is going to be very difficult.
But at least we have started having the conversation, which
Yes,
is why
yes,
it's
absolutely. We
basically
have it. Absolutely.
im-
Only to the limited extent, yes, we are looking at terminally ill patients, not beyond that.
Sir, a slightly unrelated question. How many people in India actually make a will?
Lot of people now
Any
today.
rough percentage is there?
No, there is no data because ultimately everybody do not own a property or anything which you could say yes, we are quite in a position to. But 90% they are all advised, and especially people in the cities and towns, they do have this information. Yes, making a will is much more better than keeping it without any will, to keep away the problems of having a litigation within the family. So
Okay.
that's the bottom line to that.
Abhi sir, you have another meeting, I think, lined up.
Thank you so much. It was a pleasure
So-
and honor.
Yeah. So Amrit, Tufan Pati sir. Any comments from any panelist? Tufan sir? Yes, sir.
It's a nice discussion and very controversial topic. And we are referring to two terms for reference of the speaker as well as our legal advisor. A person having enormous pain and non-remediable. And how can you define that in this background? Suppose take, for example, cancer. 90% of the cancer care in urban areas, 70% of the people live in villages. It's absolutely relative term to tell my pain to be non-remediable, unless I have been offered the best of treatment or at least moderate level of treatment that is available to an outpatient here. And it is the responsibility of the state. Staying in a remote corner in a village, if I am denied that privilege, and if at any point in time I have given an advance directive and persuasion by someone, and if that is utilized for assisted euthanasia, I don't call it suicide, then it is a grave act. It is where our law fails, it is our medical care fails, and it is where we are now. All these terms that we discuss are not generally applicable in our country. Think of the over out-of-pocket expenditures for a terminal ill patient. On average, how many average Indian families can afford it? Right? To go to statistics of pay, you see.
Thank you, sir. Thank you so much.
So ये controversy चलता रहेगा, and we have got jurists to help us. Thank you, Mr. Nicholas, and thank you, Amanullah, Dr.
Amrit, a quick thank you, sir's meeting has started. Shabir sir's another meeting has started. Amrit.
Okay. नहीं वही बोलना चाहता था कि इंडिया में euthanasia will be based on financial capacities and capabilities, not on anything else, and that would be a sorry state of affairs. We need that's the only distressing part. I think euthanasia is one of the best things. If given a choice, I would always write a will that based on these situations, if it comes to that, please inject me or do something like this, and it's a decision I would always stick to. So anyway, a lot of miles to cover before we reach that point. And thank you so much, Savitsa. It was wonderful. We had Thursday Musings had a lawyer today, top ranked lawyer, who happens to be.
I think Samrit's connection is down. Sir, thank you so much. Thank you, everyone. It is a pleasure having another specialty, a lawyer, a Supreme Court lawyer with us. Nikhilesh ji, thank you so much for joining us. Chairpersons, Abhay sir.
I'm back. There's an internet problem. So thank you, everybody. It was wonderful having all of you. It was a little different, but Thursday Musings is famous for being a little different than any other musings which you have. And we had a lot of people across the globe joining us. TSS sir is a proud man today. He's still smiling and beaming. Thank you, everybody. Thank you, Tufan sir. Thank you, Alim, for being the SA node of Thursday Musings. And I think the whole team needs that needs a pat on the back. So congratulations for bringing something which would be relevant after 5 years and making it relevant today. We need to discuss. We need to put things into force. Who knows? MHCA 25 will be in the offing, and Sanjay sir will be sitting on it. So thank you, everybody. And we'll have another musings next week. Good night.
Good night.
Rob is very, very happy. We knew
Good night.
Shabir would be a great man someday at that time, long ago, 30 years ago.
Absolutely, absolutely.
Thank
Bye bye. Good night.
Good night. Good night, everyone.